I would love to introduce Dr. Joanne Stone, who is also a maternal fetal medicine specialist in New York City. Dr. Stone is at Mount Sinai Hospital. She is a favorite of lost moms who are pregnant again in New York City, and many of our Push for Empowered Pregnancy team members actually saw her as their own physician. And she is also looking into starting the first Rainbow Clinic at Mount Sinai.
Thank you so much. I really want to thank Samantha and Harvey for this great honor and privileges. And it's just a tremendous pleasure to be part of this and move this important movement forward. I have to say that caring for patients and their families who've suffered a loss in a future pregnancy is one of the most challenging and humbling things that I do. Holding their hand during the process, understanding their pain and anxiety, and finally seeing them with a healthy newborn is one of the most rewarding moments in my professional life. So I thank you for this opportunity to be part of this event today. I also want to thank the speakers, all who've done like tremendous work, and especially Dr. Hazel, who's provided really the template for building this clinic. So just a little background that I know you are all aware of, but stillbirth affects about 1 in 160 births in the US. And we know that there are certain risk factors that increase that rate of stillbirth. So things like Black race, age 35 and older, lower socioeconomic status, cigarette smoking that's been mentioned, underlying medical conditions such as diabetes and obesity, which have really been on the rise, and chronic hypertension, multiple gestations, and most important, I think, to this group is prior pregnancy loss or stillbirth. And you can see over here the stillbirth rate over time. In the blue is early fetal losses, and then this is later fetal losses that occur 28 weeks or greater. And you can see that there's been a decrease over time, but really over the last 10 years, it's pretty much been flat. And I think this highlights the importance and the impetus to moving the needle forward on this further reduction. You can see that the rate of stillbirth varies considerably by race and ethnicity of the mother. The rate for non-Hispanic white women, for Asian and Pacific Islander women and Hispanic women is generally in a similar rate, but does start to increase for American Indian or Alaska Native women and those of non-Hispanic Black race. And it's very important to for physicians to be aware of this, and patients also. This slide also highlights the fact that for the years between 2014 and 2016, we really haven't seen much of a change when we look at perinatal mortality, late fetal loss, and early neonatal loss, which is within 7 days after delivery. This is a scorecard from Star Legacy Foundation looking specifically at New York. And what it highlights is that the stillbirth rate is highest at the extremes of maternal age. And especially starting at age 35 and higher, you can see the tremendous increase in stillbirth. And here in New York City, I always tell patients, 35 is a new 25 and 40 is a new 30, because almost everybody's having their children in this later time period. And then again, this is highlighting the stillbirth rate by maternal race and ethnicity. And New York City is such a diverse population that it becomes so important that we have a center that takes into account the diverse population of New York. So rationale for starting Rainbow Clinic in New York City. Women with a history of stillbirth have at least a twofold, and Dr. Hazel mentioned about a fourfold increased risk for stillbirth in a future pregnancy. And in New York City, approximately 700 stillbirths occur each year, which is just a tragedy. And so there truly is a need for specialized care. This is taken from a slide that from Dr. Hazel, who presented the full slide. But for me, when I saw this slide given to me by Samantha several months ago, I thought that really what struck me was that having a part of stillbirth profoundly alters the reality in the subsequent pregnancies, and I see this with my patients. It attempt to meet needs by providing additional antenatal appointments and surveillance. We see patients just on a much more frequent level. Professionals' capacity to provide adequate emotional and psychological support is truly important, and especially delivering highly sensitive care. And this is true of not only the physician, but all the support staff. So this is our roadmap to building the New York City Rainbow Clinic. This all started back in February 1st at a concept meeting with Samantha, as well as another lost mom couple and Harvey Kleinman. We got together on a Zoom call and discussed the background of the PUSH initiative and pregnancy lost moms. This led to a discussion about the Rainbow Clinic in the UK. Then we received February 2nd from Samantha, the first Rainbow Clinic proposal. Then in March through April, I started having meetings with my hospital administration, looking at the financial implications on how we go about doing this. And then now we're up to developing the logistics for implementation. So this is sort of the New York City Rainbow Clinic based on the UK model. This is our office. This is our faculty practice on the border between the Upper East Side and East Harlem. This will be a multidisciplinary specialist clinic involving myself as a maternal fetal medicine specialist and my colleagues, psychological support, mental health services, nutritional support, training of staff. And this was mentioned before. This is really so important. I learned a lot from just listening to Samantha talking about, certain ways that you can just trigger, an emotional concern just by the way you talk to a patient. Also, we're going to have an EPIC interface to identify patients as part of the Rainbow Clinic. We're going to start with half a day a week. This will be either preconceptional counseling or the first OB visit, and then subsequent visits will be incorporated into the individual physician schedule. And we also want to connect patients for support. So this is taken again from Dr. Hazel, preconceptional history, going over the pathology, and it may also be a new OB visit, performing an ultrasound for viability, document not the plant, although nice to give patients plans, but document the plan. Talk about genetic testing, especially if there has been a prior genetic issue or first trimester screening. The nuchal translucency scan is incredibly important because this identifies the correct dating, which is extremely important when you're thinking about issues with fetal growth. Also, this nuchal translucency scan is a time that we can see the anatomy very well. Again, frequent ultrasounds and estimating placental volume. Doing ultrasounds for growth is incredibly important, doing the right Dopplers. And then fetal movement awareness, as has been mentioned before, and psychosocial support for patients. Planning the delivery is incredibly important, and I'm happy to say that the new guidelines allow us to deliver prior to 39 weeks now. It was very restrictive before, but now the new guidelines for earlier delivery. And then support around the birth and the postpartum period, because it can really, again, lead to a lot of psychological stress. So, and I think the individualized management is very important. And again, going back to the initial cause of the first stillbirth, doing the proper genetic workup, looking for the presence of growth restriction, the evaluation of the placenta has been mentioned before, and looking at cases where there was a small placenta or a cord accident. Optimizing maternal medical conditions. So if they have hypertension or diabetes or antiphospholipid antibodies, really optimizing that management. Dietary and weight and smoking cessation is very important, as obesity is a risk factor. So weight reduction if you have the time to do that, and then potential therapies as appropriate. So as mentioned, low dose aspirin is really key, and heparin as appropriate. And very, very, very important is the frequent monitoring of the pregnancy and counseling about fetal movement. So ultrasound plays a really key role in the management. So this is what we use to estimate fetal weight. These are the cases of abnormal Dopplers. In the case of fetal growth restriction, we're looking at umbilical artery Dopplers, ductus spinosus, and uterine artery Dopplers. Biophysical profiles are frequently done. We usually start them at a time when a patient would intervene and increase the frequency in the third trimester. And then this is from Dr. Kleiman's incredible work on estimating placental volumes, and this is done at the time of the growth scan. So just in summary, we're hoping that this Rainbow Clinic is going to improve the patient experience, reduce fear and anxiety surrounding the current pregnancy, add to the body of research, and ultimately improve outcomes in reducing recurrent stillbirth. So I want to thank you so much for letting me be involved in this tremendous process. Thank you.
Thank you so much, Dr. Stone. It was amazing to hear about everything that you guys are doing. And we are just so, so excited to have more options for quality pregnancy after loss care in New York City.